I always tell myself that I hope this video won't be long, but I always get carried away. Grab your piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at HIV treatment in children and in pregnant women. I decided to actually combine parts 4 and 5 in one because I realized that it will make much more sense discussing them together than discussing them as separate things, because often children and their mothers almost intertwined. If you haven't yet subscribed to the channel, please subscribe to the channel, hit the bell notification icon to be receiving notifications of such videos every time I post. Drop a comment, drop a like, grab your piece of paper, and let's go. In the previous videos, we looked at the HIV basics, the diagnosis in adults, and the treatment guidelines in adults. We also looked at the HIV drugs as part of an interlude. In this video today, we're going to pretty much look at the treatment guidelines in pediatric patients, both prophylaxis and treatment, and we'll also look at the treatment of HIV in pregnancy. This is indeed the second last video. I will release the last video later on the channel today to conclude HIV week, and we will have a live stream over the weekend, so please stay tuned to that. Here's our warm-up question. Cryptosporidiosis in an HIV infected patient: A, an AIDS-defining illness if chronic; B, likely to present with profuse painless diarrhea alternating with constipation; C, likely to resolve spontaneously; D, does not improve with improved immunity. So keep this question in mind. I will give you the answer at the end of the lecture. So here are some recommendations. We want to treat all HIV positive individuals regardless of their CD4 count, regardless of their WHO staging. The extended prophylaxis in HIV-exposed infants is now going to be using AZT, 3TC, and boosted lopinavir for at least 12 weeks, or at least the duration of which the child is exposed to HIV, or you can say 6 weeks after they stop breastfeeding. Then, of course, PrEP is going to be offered for pregnant women as well as breastfeeding women. I already did a video on PrEP. I will actually leave it tagged at the end such that you can watch the video on PrEP. I did one that was on PrEP as well as PEP. Then, of course, TDF, XTC, and DTG, just like with the adults, is also the first line in children, in adolescents to be specific. Tenofovir alafenamide is going to be recommended for children that are above 25 kilograms. Then tenofovir lamivudine and dolutegravir in children that are greater than 30 kg. Now, what are the 4-prong approach for elimination of mother-to-child transmission? Now, the first thing is that we can address prevention of mother-to-child transmission at the level of women of childbearing age. We can address it at the level of women who are living with HIV. We can address it at the level of women that are pregnant and breastfeeding, living with HIV, as well as we can address it at the level of children that are living with HIV. So primarily, we want to prevent HIV among women of childbearing age. So we should do everything to prevent HIV from infecting women of childbearing age. The second prong is, of course, we should prevent unintended pregnancies among women living with HIV. So every pregnancy of a woman that has HIV must be planned, because the woman must actually fall under certain criteria so that the risk of transmission from the mother to child can be greatly released, or greatly reduced. No child in 2022 must actually be born with HIV. And of course, the third prong is prevention of HIV from a woman living with HIV to her infant. If you can't really prevent the unintended pregnancy, at least try and prevent the transmission of the HIV from the mother to the child. And then the fourth thing is provision of appropriate treatment, care, and support for children living with HIV and for their families as well. So this is a four-prong approach in elimination of mother-to-child transmission. Now, what are some of the tests that we do for women, pregnant women, during the 3 semesters? So in the first semester, if the child-bearing female has a negative HIV test and those that have a positive test. So on this column here, this is those that have negative HIV test, those that have positive HIV test. So we're going to start with those that are negative. So we screen for hepatitis B, we screen for syphilis. If they are positive, we treat them as well as tell their partner to come in. So we treat the partner as well. We should counsel them and initiate PrEP if they are eligible, if their partner is positive and they are negative. Then of course, counsel the patient and the client and the partner on HIV combination prevention. So provide them with condoms and information on where they can access condoms, even female condoms, which are known as femidomes. Then of course refer to youth-friendly services for more comprehensive sexual information, including HIV prevention, and retest them every 3 months. Okay. In pregnant women, we retest them every 3 months. Then if they are positive, we want to counsel them and initiate them on ART. We screen them for hepatitis B, syphilis, and other opportunistic infections, and we treat the client and the partner if they are positive. So at the first antenatal visit, if they are a known positive patient, we want to check if the viral load was done. If the viral load was done, but it was more than 3 months ago, we want to retest and repeat the viral load. If it was greater than 3 months ago, then we repeat the viral load and we retest and we do the viral load every 3 months. Then for those that initiate ART in antenatal, we do the viral load at 3 months, and then afterward we retest every 3 months. We do the viral load every 3 months. We should also provide them with condoms or information on where to access condoms, including the female condoms. In the second trimester, we also, if they are negative, we screen them for hepatitis B, we screen them for syphilis. Of course, we treat any positive clients together with their partners. And then, of course, we should counsel them and initiate them on PrEP if they're eligible. We should counsel them and their partner on HIV combination prevention. So it's similar to what we're doing in the first trimester. If they're positive again, we initiate them on treatment. We screen them for the hepatitis B, the syphilis, the opportunistic infections, and treat them if they are positive together with their partners. Now, at the first antenatal visit, the management pretty much is the same. If they haven't done the viral load greater than 3 months, if they come in the second trimester, repeat the viral load, and then you'll be doing it every 3 months. Then, of course, provide them with condoms and information on prevention of HIV transmission. Then, of course, if they come in the third trimester, we screen them again for hepatitis B, syphilis, and if they are positive for this, we treat them with their partner. We counsel them and initiate them on PrEP if they are eligible, as well as counsel the client and the patient on the combinational HIV prevention methods. Then, of course, if they are positive, we counsel them and we continue them, or you start them on ART. We screen them for hepatitis B, syphilis, and opportunistic infections. We also check if the viral load was done, and if it was done more than 3 months, then we repeat. Then we should repeat the viral load about 1 to 4 weeks before the delivery. So make sure you do the viral load 1 to 4 weeks before the delivery. Provide them with condoms regardless, as well as information concerning HIV. Then, of course, those that are coming in labor and delivery, we do an HIV test if it wasn't done in the past 6 weeks. Or if the last test was done more than 6 weeks ago, then we counsel them and initiate them on ART if they are positive. Now, what about with infants and children? I already talked a little bit about this when we talked about diagnosis. So here we are going to start off at birth. So a child, female with a negative HIV test, as well as a childbearing female with a positive test. What do we do? Because these children are exposed to HIV. So if they're negative, then we do the HIV test. If it was done more than 6 months ago, we counsel them and initiate them on PrEP if they're eligible. Then, of course, we counsel the client and the partner on HIV combination prevention. Now, if the child is HIV exposed, meaning that they have the risk of getting HIV, they may not necessarily have the HIV, but they have the risk of getting HIV. So you send a dried blood spot or fresh blood for nucleic acid testing. We send blood for syphilis, that's your RPR, and we schedule the immunization schedule. Now, if you get a positive NAT, a nucleic acid test, we send a fresh DBS or blood for confirmatory NAT. Then, of course, we initiate them on treatment. Your AZT, 3TC, and nevirapine for 14, and then after we change it to ABC, 3TC, and boosted lopinavir. If the RPR is positive, then we treat them for congenital syphilis. Then if it's negative, then we initiate them on AZT, 3TC, and nevirapine prophylaxis for 12 weeks. And of course, if the RPR is positive, we treat them for congenital syphilis. We should counsel the mother on adherence counseling, as well as continuing them on ART. If they haven't yet started on ART, we start them on ART, and then we also initiate infant feeding counseling. Then the next time we're going to meet this child is at 6 weeks. So we do the test if it wasn't done, or if it was done more than 6 weeks ago. Then we counsel them and initiate them on PrEP if they are eligible. We counsel the client and the partner on HIV combination prevention methods, provide them with condoms, provide them also with information on HIV. Then, of course, if it's a positive nucleic acid test, we start them on cotrimoxazole prophylaxis. We continue them on ART if they were already started on ART. We schedule the immunizations. And then, of course, if it's a newly diagnosed individual, we start them on ABC, 3TC, and boosted lopinavir. Then, of course, continue adherence counseling. If it's a negative NAT, start them on cotrimoxazole prophylaxis, send a dried blood spot and fresh blood for NAT, and then continue ART prophylaxis with your AZT, 3TC, and nevirapine. If never breastfed, then you can stop the prophylaxis. Then, of course, continue adherence counseling and as well as infant feeding counseling. This should be done throughout every single time when you actually meet the mother. And then when they come in at 10 weeks, we do the test if it wasn't done in more than 6 weeks ago. We counsel them on PrEP if they're eligible, and pretty much the rest of these things are the same as what we're doing in the previous visits. So if they are positive, we continue them on cotrimoxazole, we continue ART, we continue adherence counseling, we schedule immunization. If we are initiating them, any newly diagnosed, we should initiate them on ABC, 3TC, and boosted lopinavir. Then, of course, if they're negative, continue the cotrimoxazole, continue the prophylaxis, which is AZT, 3TC, and nevirapine. Then, of course, schedule the immunization. Viral load testing on the mother, as well as adherence counseling testing and infant feeding counseling. Then the next time they'll come in is at 14 weeks. Again, if they haven't done the test in the past 6 weeks, we should redo the test. Then, of course, if there's a positive NAT, we continue on cotrimoxazole prophylaxis. We also continue the ART, we continue on adherence counseling and schedule the immunizations. Then, of course, if they're negative, if the mother is virally suppressed, we can actually stop the AZT, 3TC, and lopinavir. Remember, we did the viral testing at 10 weeks. Now, if the mother is not virally suppressed, we want to continue the AZT, 3TC, and boosted lopinavir for as long as the child is exposed to getting HIV. For as long as the child is breastfeeding. We can only stop this 6 weeks after cessation of breastfeeding. And of course, if the mother is virally suppressed, we continue with the same regimen. If the mother is not virally suppressed, then take action to ensure that the mother is on a drug regimen that actually is going to work and suppress her viral load. Then, of course, we should also initiate them on ABC, 3TC, and boosted lopinavir if we do find that they are positive, the children. Then, of course, the next time they come again is going to be at 6 months. We do the same thing. If the test hasn't been done in the past 6 weeks, we do, and then the counseling and everything else is pretty much the same. Even for 9 months is pretty much the same. If they are positive, pretty much cancel them and continue them on cotrimoxazole, continue ART, continue adherence counseling, schedule the immunization. If they are positive, initiate them on ABC, 3TC, and boosted lopinavir. Same thing at 9 months. Then if it's a negative NAT, send a DBS or fresh blood for NAT. And then, of course, at the next child visit, you should stop the AZT, 3TC, and nevirapine prophylaxis if the mother is virally suppressed. If they're not, we continue the prophylaxis. If NAT is positive, we should start them on treatment. Same thing is happening at 9 months. Then, of course, there should be viral load, adherence counseling. We should continue the ART and review in about 2 to 4 weeks with results of the viral load. So within or at the time of the next child visit. Then, of course, at 12 months, again, this is pretty much the same column. than what I've been explaining. Even this is pretty much the same column as what I've been explaining at the previous visit. Even this now, this changes here. We're going to be doing serology test. If the serology test is positive, then we send blood for DBS or fresh blood to confirm with NAT. Then, of course, if the viral load is suppressed at the next child visit, we stop the prophylaxis. We continue the prophylaxis if they are not, and then if the NAT is positive and confirms that the child is positive, we switch them to ABC3TZ and boosted lopinavir. Viral load adherence counseling, review them in about 2 to 4 weeks with, of course, the results of the viral load. Then, of course, at 18 months, this column is exactly the same. Of course, even this column is the same. This column also is the same. At 24 months, remember that after 12 months, that's where we're going to be starting with a serological test. If they are NAT negative, we test them with serology. Then we do the same thing at 24 months, pretty much the same. So when their child is 2 years. Now, what's the management of an HIV exposed infant and extended prophylaxis? So all HIV exposed infants should actually receive prophylaxis for at least 12 weeks with AZT, 3TC, and nevirapine. Remember, we're using 3 drugs for prophylaxis. Then it's supposed to be stopped when there is documented suppression of the viral load in the mother at 3 months postnatal. Then, of course, in a situation where the viral load is not suppressed or the mother is not NAT, we should continue the prophylaxis to the child as long as the child is exposed, and we should monitor for side effects. Then the prophylaxis should be extended until the mother is suppressed or 4 or even 6 weeks post breastfeeding is stopped. Then, of course, where the mother refuses to be on treatment, continue counseling, and you should initiate ART as soon as possible in the mother, and the baby should continue the prophylaxis. Counsel the mother and educate her on the risks that she's putting the child at contracting HIV. Now, what's the dosing that is there? I just put this intentionally so that you can have a look at the dosing. So the AZT and 3TC come together as a suspension, and the nevirapine also comes together as a syrup on its own. So if it's a child that has been born up until they are less than 6 weeks old, if they're weighing 2 to about 2.5 grams, if it's AZT, we give 1 ml of the suspension twice a day. It contains 10 milligrams of AZT, 5 milligrams of lamivudine. Then, of course, if it's nevirapine, we give 10 milligrams once a day. So that's 1 ml of the syrup. So you're going to give 1 ml of this AZT 3cc syrup twice a day. We give 1 ml of the nevirapine once a day. Then in those that are between 2.5 to 3 grams, we're pretty much going to be giving them our 1.5 mils of the suspension twice daily and 1.5 mils of the syrup once daily. So the nevirapine is given once, AZT and 3TC are given twice. Then, of course, those that are 3 kg to about 6 kg, or those that are between 6 weeks to 12 weeks, we use the tablets. So we use the combination of the 60 milligrams to 30 milligrams tablets. We give it twice a day. Then, of course, nevirapine, we give the 20 milligrams once a day. And of course, this is the 2 mils of the syrup once a day if you're using the syrup, or a 50 milligram, half of a 50 milligram tablet if you're using this once a day. I think it's better if you use the syrup, because I usually have some reservations concerning breaking tablets in half. Now, remember that the AZT3TC is dispensed, is a dispensable or dispersible tablet containing AZT 60 milligrams and 3TC 30 milligrams. And of course, meaning that you can actually dissolve this tablet in water. It's dispersible. So you can dissolve one of these tablets into about 6 mils of water. So 1 mil of the suspension is going to be containing 10 milligrams of AZT and 5 milligrams of 3TC. So you have to take note that the suspension made should be kept in a cool place, and daily reconstitution is actually recommended to assure that there is stability of the suspension. So you should shake the bottle before you use it. Then, of course, for infants that are less than 2 kg and those that are older than 35 weeks of gestation age, then the suggested doses for nevirapine are 2 milligrams per kg per dose once a day for nevirapine, and then AZT 4 milligrams per kg twice a day. Then for the premature infants younger than the 35-year gestational age, then you should dose them using expert guidance, so consult someone who has experience in this. Then of course, caregivers should be educated by the pharmacist as well as the clinicians on how to reconstitute the AZT and 3TC dispersible tablets. So you should tell them 1 tablet in about 6 ml of water. Then of course, the caregiver should demonstrate to the pharmacist how they're going to be reconstituting the formulas. Now, always counsel them on adherence and the benefits of starting ART. This I think I talked about in the previous video. So the reduction in HIV-related morbidity and mortality, reduction in mother-to-child transmission, those that are breastfeeding and those that are pregnant, as well as potential reduction in the incidence and severity of chronic conditions, so renal disease, liver disease, certain cancers, neurocognitive disorders, even reduction in infectious complications like TB. Then of course, they should be also reduced sexual transmission of HIV. This is more important for the mother. Now, when we test them and we find out that they are not infected, we should provide them with information about, of course, the counseling and the HIV services that we offer, the PrEP, the PEP, and then of course establish the partner status, retest them after 3 months. If you find out that they are positive, if they're a child less than 5 years, start them on cotrimoxazole prophylaxis. If they are pregnant women, start them on cotrimoxazole prophylaxis. If they're a child greater than 5 years old or they're an adolescent and their CD4 count is less than 350 cells and they have WHO stage 2, 3 or 4, start them on cotrimoxazole prophylaxis. Screen them for TB, screen them for cryptococcal meningitis, screen them for renal insufficiency, and then start all patients on treatment regardless of the CD4 count, regardless of the WHO staging. Then of course the baseline tests still have to be done. Now, these are the pre-initiation tasks, which I pretty much alluded to when I spoke about this in the previous video, so I won't spend much time actually looking at this diagram because I really talked about it in depth in the previous video. If you've forgotten about that, I will leave this on the screen for a few seconds so that you can actually get a screenshot and you can actually read through at your own pace. Then, of course, I also talked about this with the same day ART initiation. This is just here to remind you that some patients can actually start on treatment on the same day. So this is just a self-explanatory flowchart that you can actually have a look at. You can pause the video. I explained it in the previous video. So again, if you have no idea what it's all about, if you're just watching this video as a standalone, please make sure you watch the previous video as well. I'll leave it tagged at the end of this video. Now, what's the first line antiretroviral regimen? So we want to provide optimized fixed dosing ART regimens in all population. So we also want to consistently demonstrate that these regimens have better clinical and laboratory outcomes. So if patients are started on treatment early, there is a better chance that they may actually respond very well. There is reduction. We want to reduce the time in between the HIV diagnosis and the initiation of the combined antiretroviral treatment. Then of course this is based on whether the person is ready to start, and it is preferred that initiation is done at least within 2 weeks or immediately. So now these are the drugs. Now here I want to take some time because I already talked about adults and adolescents, so this is pretty much the same. In adults, what I discussed in the previous video concerning adults is the same for adolescents. So those that are between 10 to less than 19 years and those that are weighing greater than 30 kg, it's pretty much the same. With the pregnant and the breastfeeding mothers, I also alluded to it in the previous video. I talked about TDF, XTC and dolutegravir. An alternative regimen is TDF, XTC and efavirenz, but not the efavirenz that is 600 milligrams, but the efavirenz that is 400 milligrams. Then of course we talked about also ABC, 3TC and dolutegravir. Now, remember that the efavirenz 400 is a lower dose, and it's actually preferred for those that are having HIV and being treated for HIV, but they have TB at the same time. Then, of course, if nevirapine exposure was there, then the alternative is using a protease inhibitor-based regimen. I'll talk about this very shortly. Then of course tenofovir alafenamide should be avoided in pregnancy. Then it should avoid it in patients that are on rifampicin treatment. It's not recommended. Then we can either use for this annotation that says D over there, we can either use 3TC or FTC, which is what I suppose XTC stands for. So XTC can either be 3TC or FTC, which is pretty much lamivudine and emtricitabine. Sorry, it's cold and I'm tired. Then FTC is not available as a single drug and is actually expected to be part of a fixed dose regimen which has tenofovir alafenamide, the emtricitabine, as well as the dolutegravir. So it comes as a combination, a fixed combination. Then of course dolutegravir is given to those that haven't taken ART before. Then for those that are on TB treatment and they have HIV and they're taking rifampicin, and those that can't tolerate the efavirenz 400, we should increase the dosage of DTG, because remember that rifampicin is an inducer of UDP glucuronil transferase, S transferase, which actually metabolizes the DTG. That is why we're actually increasing the dose of DTG. If this sounds like Greek to you, then you should watch the video on the HIV drugs. Then, of course, ABC3TC and dolutegravir can be used as an alternative for those that have renal insufficiency, where TAF is not available and efavirenz is not tolerated. So now let's go into the regimen. So here we have a child that is between 0 to 2 weeks, of a child between 2 weeks to 5 years, and then we have a child that's co-infected with TB. So all children that are 0 to 2 weeks, so for 14 days, we put them on AZT3TC and nevirapine. We can actually use this for treatment, and what you have actually realized that we also use this for extended prophylaxis. Then of course an alternative is AZT3TC and raltegravir, which is an integrase inhibitor. Then for the children that are between 2 weeks to 5 years, if they're less than 20 kilograms, ABC3TC and boosted lopinavir, alternatively AZT3TC and boosted lopinavir, or AZT3TC and raltegravir. Those that are between 20 to 25 kg, ABC3TC and dolutegravir. So here you can use dolutegravir. Then an alternative is AZT3TC and boosted lopinavir, ABC3TC and boosted lopinavir. Then of course those that are greater than 25 kg, tenofovir alafenamide, 3TC and dolutegravir. Then an alternative is ABC3TC and dolutegravir. Those that are greater than 30 kilograms, the same regimen, but as an alternative you can use TDF in those that are greater than 30 kilograms. We can't use TDF in those that are between 25 to 30 kilograms. We use TAF. So TDF is only recommended for those that are greater than 30 kg. Then those that are less than 20 kg, then we use ABC3TC and raltegravir. Remember to double the dose of raltegravir, or ABC3TC and AZT. This is rather a strange one. Then of course AZT3TC and efavirenz if they're greater than 3 months. Then of course for those that are 20 to 29.9, ABC3TC and dolutegravir, increase the dosage of dolutegravir to twice a day, 50 milligrams twice a day, because of the drug-to-drug interaction between dolutegravir and rifampicin. Then of course an alternative is ABC3TC and boosted lopinavir. Remember that boosted lopinavir should be super boosted, otherwise you should consult the expert opinion. Or you can use ABC3TC and efavirenz, or ABC3TC and raltegravir. For those that are greater than 30 kilograms, TDF3TC and dolutegravir. Of course, increase the dose of dolutegravir to 50 milligrams twice a day. The treatment regimen in pregnant women as well as in adolescents and adults I did cover in the previous video. Now what about with HIV type 2? Remember that in HIV type 2, the only PI that works against HIV type 2 is our boosted lopinavir. So our first line again is still going to be TDF or TAF, XTC plus dolutegravir. In adolescents and adults, in children is going to be ABC3TC and boosted lopinavir. An alternative regimen in adults and adolescents is of course your TDF or TAF, XTC and boosted lopinavir, or boosted darunavir. Then of course ABC3TC plus boosted lopinavir, or boosted darunavir, ABC3TC or dolutegravir. Now we should also monitor them clinically and laboratory. Remember that clinical monitoring is going to be including our history and examination, as well as evaluation for adherence, side effects, as well as relevant drug toxicities. Then our laboratory tests need to be conducted routinely and as needed, and these are going to be including things like CD4 count, viral load testing, as well as toxicity monitoring. And the purpose is of course to evaluate if the treatment is working, and of course diagnose treatment failure quite early on, evaluate adherence. We want to screen for pulmonary tuberculosis, detection of any toxicities of ARVs. Then of course the viral load is recommended as a proxy to actually see the effectiveness of the treatment as opposed to CD4 count. But if you can't really do the viral load, then CD4 count and clinical monitoring can be done. So here's an algorithm of the viral load testing. So we test the patients on ARTs, those that have been on effective ART for at least 6 months. And then at 6 months, we do a viral load. If they are less than 1,000 copies, then we continue adherence support and ART, and then repeat at 12 months after the initiation. Then we do it annually. Then, of course, if they're greater than 1,000 copies, meaning that they are not virally suppressed, we enhance the adherence counseling. Then we repeat within 3 months of the last viral load. If the viral load is still greater than 1,000 copies, we say that these people have virological failure. Then if they are on first line treatment, we switch them to second line treatment. We collect blood for genotypic testing. Then of course we modify the second line ART according to the genotypic results that we receive. Then of course if they are on second line, we do the genotypic testing. Then of course we should consult an advanced treatment center on what you should do next. Then of course, if it's a known HIV positive patient on ART greater than 3 months, we check the viral load if the viral load is present on their file. If not, we trace it. If the viral load was done more than 3 months ago, we do the viral load and we retest them every 3 months. This is for the pregnant women and the breastfeeding women. Then of course, if they are pregnant, we book them for viral load retesting within the 4 weeks of the delivery, within the 4 weeks of the expected date of delivery. Then if the viral load was done less than 3 months, then we should do it at 3-month intervals. Then of course we should book them to do viral load testing 4 weeks before the expected date of delivery. If the viral load is not found, we do the viral load, and then of course we test them every 3 months. And then if they're pregnant, we book them for viral load retesting within 4 months of the expected date of delivery. If it's a known positive patient that's on ART and less than 3 months of them, or they are newly diagnosed on ART, we do the viral load at 3 months from the last viral load. Then of course we retest every 3 months, and then if they're pregnant, we book them for viral load retesting within 4 weeks of the expected date of delivery. I think I talked about this in the previous video. Now, there is some clinical and laboratory monitoring, and pretty much this we also talked about in the previous video, where you actually do your history and order for some lab tests at enrollment and the initiation of ART. 2 weeks post initiation, 4 weeks post initiation, 12 weeks post initiation, 6 months, 12 months. And I think I talked about this in detail in the previous video. So just head over there. I'll leave this on your screen for you to get a screenshot so you can actually have a good idea of what is happening here. Then of course, in pregnant women, I did say that I'm going to spend much more time here in the previous video because I wasn't focusing on pregnant women and breastfeeding women in the previous video. So here, at the first time when you initiate this patient, you want to take a history and examine them. If they're pregnant, of course, perform focused antenatal care, screen them for TB and Cryptococcus. Adherence counseling is very important. Of course, initiate them on ART after adherence counseling. Then, of course, if there are no signs and symptoms of active TB, initiate them on ISONIAZID TB prophylaxis. These should be positive health, daily, and preventive messages that should be offered for this patient. Then of course some laboratory tests include serum creatinine, ALT, do your HB or your full blood count, do your CD4 count, do your hepatitis surface antigen test, syphilis test, viral load at the first time of contact if they are eligible. Remember I looked at the previous flow charts that I was showing you about viral load. Then of course urinalysis for any proteinuria, glucose, and even RBCs. Check for the cholesterol and triglycerides, especially if you're starting them on a protease inhibitor based regimen. Then of course 2 weeks after, we want to take a targeted history and examination, do your serum creatinine and urinalysis. Then of course do these things as they are needed. And then of course screen for TB and Cryptococcus and other OIs. Same thing that you should do at 4 weeks post initiation. And of course for the subsequent visits, then antenatal care if they're pregnant. Of course, for the HIV exposed infants, you schedule for the postnatal and for those that are breastfeeding. Then of course in adult, ART schedules if they are postnatal and they're not breastfeeding. I talked about the different schedules of the HIV exposed infants in the very first beginning of this video. Then of course, if pregnant, antenatal care, We review adherence counseling, side effects and toxicity. We offer them adherence counseling as well as positive health daily and prevention messages. Then of course we review the laboratory testing. Then of course we refill the ART if they do not have enough supply. So the maximum that we can supply them with is about 3 months. Viral load should be done every 3 months during pregnancy and breastfeeding period. Then of course serum creatinine and urinalysis must be done at every antenatal visit. Then of course laboratory testing is supposed to be occurring, so antenatal care, with antenatal care, every antenatal care visit with the pregnant women, except for viral load, which we do every 3 months. Then of course viral load should be done 4 weeks before delivery in the pregnant women. Cholesterol and triglycerides should be done at 6 months post initiation of ART, especially during pregnancy. Then of course follow up the adult ART schedule when they have given birth, except for the viral load, which of course I did show you much earlier on. Then for the first postnatal visit, we do a CD4 count to determine the need if they need to continue our cotrimoxazole. Remember that we give this to those that have a CD4 count that's less than 350, or those that are at stage 2, 3, or 4 of HIV. And then of course 24 months after delivery, the ART is given. Then of course we transfer to the ART clinic to continue their HIV care, because they are pretty much have now gone out of this. If their children are still breastfeeding, perhaps maybe we can continue them, but most likely they would have stopped breastfeeding, so they would be seen in the adult ART clinic. Then of course early transfer or referral may be done for logistic reasons, or even complicated cases, transfer them to the adult ART clinics. Then of course, what is treatment failure? So we could discuss it as either clinical, immunological, or virological. So clinical, where you have treatment failure, should be considered where you have clinical symptoms that appear whilst the patient is on therapy. So they suggest that the patient is deteriorating. Immunological failure is where there are many definitions for this. So one definition is a drop of the CD4 count to below the pre-treatment values, or 50% from the peak value on treatment, or persistent CD4 levels that are below 50 cubic cells per cubic meter after 12 months on therapy. Then patients initiating treatment with a very low CD4 count may actually not be able to mount an adequate rise in the CD4 count. Then of course virological failure is a plasma viral load greater than 400 copies per mil after 6 months of therapy. Generally, rule of thumb is that if someone is greater than 1,000 copies after 6 months, you retest them after 3 months again after you offer them adherence counseling. If it's still greater than 1,000 copies, then they are not virally suppressed. Then this is what I've been talking about. Those that are greater than 1,000 copies, we retest the viral load within 3 months. If they're still greater than 1,000 copies, then we say that they're virally undergoing virological failure. Then of course we enroll the patient in intensive adherence counseling programs, switch them to second line, and of course consult an advanced treatment center. Then of course follow them up, review them in 2 weeks, reassess adherence, side effects and toxicity. Then if there is no treatment failure, we continue adherence and counseling. This is very important. Or every visit, counsel on adherence and compliancy. Treat any OIs, and then if the patient is still ill, examine them and treat them accordingly. Now, how do we manage patients that are on treatment failure? Remember, these are patients that have a viral load greater than 1,000 copies, for at least those that claim to have on effective treatment for 6 months. Then, of course, poor adherence is one of the most common things that is going to be causing treatment failure. So we should address the barriers that are going to be doing this. Then, of course, when patients are switched to second-line regimen, the goal is to achieve viral suppression, a viral load less than 1,000 mils. 1,000 copies per mil. Then of course, if there's clinical and immunological failure, then of course we should also optimize the adherence. We should optimize their drug regimens. So boosted lopinavir is the primary recommended second line protease inhibitor. So now, for those that were the children that was on a lopinavir based first dose or first regimen, or those that are NRRTI based first line regimen, those that are ARV naive, that never taken any ARVs before. If they have been on a lopinavir based regimen, we continue them, and we had started them on ABC, 3TC and boosted lopinavir. We now switch them to AZT, 3TC and raltegravir. So we don't want to continue the lopinavir if they have failed on it. We want to switch them to raltegravir, which is an integrase inhibitor. For those that have never taken ARVs, or those that were on ABC 3TC and efavirenz, we want to start them on AZT 3TC and boosted lopinavir. Then for the adolescents and adults is pretty much the same. We talked about it in the previous video. For the women, those that were on TDF-XTC and efavirenz, or ABC 3TC and efavirenz, we switch them to AZT 3TC and boosted lopinavir or boosted atazanavir. These are now our second lines. Then, of course, for those that are co-infected and those that have HIV and hepatitis B, as well as the pregnant and breastfeeding women and adolescents, I did talk about in details in the previous video. So you can actually just screenshot this and have a sit down. If you don't understand it, head over to the previous video. Then, of course, those that are co-infected with HIV 1 and 2, those that were on TDF-XTC and dolutegravir, or ABC 3TC and dolutegravir, we switch them to ABC 3TC and boosted lopinavir. Boosted lopinavir, like I said, is the only boosted PI that actually works against HIV type 2. Atazanavir is not active against HIV type 2. Then there is also nutritional care in HIV infected children. So we want to assess the nutritional status and the diet in these children and the symptoms at every visit. We want to order for some lab tests. So total cholesterol, triglycerides, glucose, and HB. We assess the WHO clinical stage. So we should ask about any recent diseases such as persistent diarrhea, any opportunistic infections that are associated with increased nutritional need, determine the energy needs of this child and provide additional energy. So we should measure the weight and the height at each visit and plot them against the national growth curves. So you may get normal growth, you may get underweight where the weight for age is greater than the 3rd percentile, then stunted growth where the height for age is less than the 3rd percentile, and wasted when their weight for age is less than the 3rd percentile. Then, of course, if the child has normal growth, we inform them on healthy eating habits and avoidance of obesity. We educate the mother, we educate the child if they are able to understand. Then, of course, if there is poor growth, we should get a food dietary assessment. We should assess for drug adherence if the child is on ART. Then the mothers and the caregivers should be asked about food availability, the types of foods that the child is being fed, and as well as who feeds the child, how much, how often does this child feed. We should examine for signs of opportunistic infections or wasting. We should provide them with appropriate clinical interventions, food support programs. Then, of course, if there's severe malnutrition, we stabilize them in the acute phase of malnutrition. I've talked about malnutrition as well in the pediatric lectures. Head over there after this, and I have a very good lecture on that. Then, of course, similar to the HIV uninfected child with severe malnutrition, and then we initiate them on ART as soon as they are stabilized. Then, of course, immediately after we initiate them on ART, if there is unexplained malnutrition, e.g. it's not associated with untreated opportunistic infection and does not respond to a standard nutritional therapy, and if the unknown HIV status, we test them for HIV and we consider initiating them on ART as needed. If they are on ART, we reassess the frequency and we adjust the doses as need be. Then, of course, recurrency of growth failure and severe malnutrition may actually indicate treatment failure, poor adherence, or even opportunistic infections, which have to be addressed. Now, nutritional supplementation that is actually given, we give high-dose vitamin A supplementation every 6 months for children that are between 6 to 60 months, so those that are 6 months to 6 years. Then, of course, we give zinc supplementation for acute diarrhea. Then mothers should exclusively breastfeed the HIV-infected children and young children up to 6 months minimum, and they may continue up to 2 years, but usually we exclusively breastfeed them for at least 6 months. Then infants and young children, so exclusive breastfeeding is just simply giving the baby only breast milk, no other liquids, no other solids, not even water, unless if it's medically indicated. Then thereafter, the mother should actually introduce nutritionally adequate complement feeds while continuing breastfeeding up to at least 24 months. Then, of course, replacement feeding should be only considered if it is acceptable, if it is feasible, if it is affordable, if it's sustainable, and if it's safe. Now, the infant and the young children feeding options. So if the mother is positive, then the infant status is negative or unknown, exclusively breastfeed them for 6 months and then offer replacement feeding. Then the timing where you can actually start the complementary feeds after 6 months. Then, of course, recommending timing of cessation of breastfeeding at 12 months if there is food security that is assured, then up to 2 years if there is no food security that is assured. Then for those that are positive and the infant is positive, exclusively breastfeed them for 3 months as well. Timing of the complementary feeds can be started at 6 months. Then, of course, we continue it up to 2 years. We can stop the breastfeeding at 2 years. The mother is negative, the infant status is not known, exclusively breastfeed them for 6 months. Timing of the complementary feeds is at 6 months. Beginning, not cessation, beginning at 6 months. Then, of course, up to 2 years, that's when you can actually complete or stop this child from breastfeeding. Now, what about nutrition in infected adolescents and breastfeeding women and in adults? We want to calculate the body mass index. So how do we calculate body mass index? We say the weight divided by the height squared. So we determine the BMI. So a patient can either be underweight, where the BMI is less than 18.5 kg per square meter. They are normal if they're between 18.5 to 24.9. They are overweight if they are 25 to 29.9. They are obese if they are greater than 30 kg per square meter. So if the BMI is less than 16, or they have anemia and HB less than 10, or they have TB, we should refer them to a nutritional support program. Observe them closely for treatment complications such as refeeding syndrome, undiagnosed opportunistic infection, and even iris, which we'll talk about in the next video. If the BMI is greater than 25, meaning that they are overweight, then of course we provide them with nutritional counseling, dietary advice, and the need for physical exercise. So if this is a simplified BMI related ARV drug risks. So those that are less than 1 kg per square meter and those that are greater than 20 kg per square meter. So with TDF, it causes tubular renal dysfunction, Fanconi syndrome. Then of course with AZT, it causes lactic acidosis, severe hepatomegaly with steatosis. With didanosine, it's not didanosine, stavudine. We don't really use didanosine. Stavudine, this actually causes lactic acid, severe hepatomegaly with steatosis, as well as acute pancreatitis. So we want to manage these patients with caution, and we consult the next level if necessary. Consult an expert. Now there is what we offer, which is known as a TB isoniazid preventive therapy. So daily TB isoniazid preventive therapy can actually prevent TB in people that are at high risk of developing TB. So this includes those that are infected with HIV. We screen all the patients for TB and any opportunistic infections. We do not want to start someone on one drug for prevention of TB when they actually do have TB, because that's going to be counterproductive. So we screen all pregnant women and breastfeeding women, regardless of their HIV status, for TB at every contact of the focused antenatal history. We screen all the children for TB at every contact. We give isoniazid prophylaxis for 6 months to the following cases. Number 1, if they're HIV infected less than 12 months with a TB contact, and after running out or ruling out active TB in the child. Then of course, if they're newly HIV infected, pregnant, or breastfeeding, and the children that are greater than 12 months, adolescents or adults, after ruling out active TB. Then of course, after they complete a full course of ATT, and in HIV infected children, they should be given the isoniazid preventive therapy for 6 months. We do not give isoniazid preventive therapy in a patient who's showing features of active TB. So this patient must be fully investigated for TB, and they must be started on TB treatment. If they are confirmed, you should start them on treatment. We do this to prevent TB resistance. Then of course, the standard TB screening questions are going to include the following things. Do they have any cough? What's the duration? Is it productive? Is it non-productive? Do they have unexplained weight loss, especially in the adults? Are they failing to thrive, or do they have malnutrition? In the case of children, then of course, is there fever or night sweats? Now, contraindications and when to stop the TB prophylaxis. If they suspected or confirmed active TB, start them on ATT. Do not put them on prophylaxis. Of course, jaundice and icterus, which is yellowing of the eyes, or active hepatitis, if there is a known or suspected hypersensitivity to isoniazid, or skin rash, confusion, convulsions, dizziness, peripheral neuropathies, if there's severe numbness, burning pain, muscular weaknesses of the legs and even of the arms, if they're taking medications like phenytoin, carbamazepine, warfarin, theophylline, selective serotonin reuptake inhibitors such as fluoxetine, then of course oral ketoconazole and itraconazole. These are all contraindications for patients starting isoniazid prophylactic therapy. So how do we give this isoniazid prophylactic therapy? So we give it during pre-ART period before they start the HIV treatment, and in HIV-infected children less than 12 months with a TB contact after we rule out active TB. So we should review and assess for the side effects at 1 month, 3 months, 6 months of starting the treatment. Then of course, when you're starting this, you give isoniazid and pyridoxine for 1 month, isoniazid and pyridoxine, which is B6, for 2 months, isoniazid and pyridoxine for 3 months. Then of course, we should always give pyridoxine 25 milligrams once daily, because we want to prevent the side effects of isoniazid in pregnant women, in breastfeeding women, in adolescents and adults, which is pretty much your peripheral neuropathy. Then of course, here is a diagram of the cotrimoxazole prophylaxis, isoniazid prophylaxis, pyridoxine, as well as the different dosages and the combinations of these drugs. There is a tablet which is combined, there are tablets which are single, and there are suspensions. This is the dosage that we have of these drugs in the different age groups. So take your time and actually have a look at this. You can get a screenshot, it may be helpful to you. Then what about cotrimoxazole preventive therapy? So we give this to prevent pneumocystis jirovecii pneumonia, toxoplasmosis, isosporiasis, malaria, and HIV and other non-HIV related diseases. So this can actually prolong the survival. In HIV-infected pregnant women on cotrimoxazole prophylaxis, they should not be given sulfadoxine and pyrimethamine, because remember, we give sulfadoxine and pyrimethamine as malaria prophylaxis in pregnant women. But if they're already on cotrimoxazole prophylaxis, there is no need to give the sulfadoxine and pyrimethamine. Now here is when to start and when to stop, and whom to start on the cotrimoxazole prophylaxis. So if it's a pregnant woman, we start as early as possible, and we do not give them sulfadoxine and pyrimethamine. Then we start them on cotrimoxazole after 14 days if they were taking sulfadoxine and pyrimethamine. Then of course continue it throughout the pregnancy. If they're breastfeeding, we continue if their CD4 count is less than 350, or if that's stage 2, 3, or 4. Then of course, if the CD4 count is greater than 350, then we can actually continue them for a consecutive 2 weeks, at least 6 months apart, while they are on ART. Then of course, if it's a child, if they're exposed to HIV at 6 weeks old or at first contact, we confirm that the HIV uninfected after full cessation of breastfeeding, then we can actually stop it. Then if they are less than 24 months, we start them regardless of the WHO staging, regardless of the CD4 count. If they are greater than 24 months and less than 5 years, we start them those that have a CD4 count less than 25%. Then those that are at stage 2, 3, and 4. Then of course, those are at stage when you start this, once they reach 5 years old or they have a CD4 count greater than 25%, and those that are at stage 1, you can actually stop it. Then of course, when you make a presumptive diagnosis of HIV less than 24 months old, we start them regardless of the WHO staging, regardless of the CD4 count. We stop if we confirm that they're HIV negative. If they're infected, we stop it at 5 years or when the CD4 count is greater than 25%, or when they are at stage 1. Then of course, in the children 5 to less than 10 years, and those adolescents and adults, a child with a history of PCP, we start them on treatment. HIV infected children greater than 5 years, or adolescents or children, but those that have a CD4 count less than 350 or WHO 2, 3, or 4 stages, we start them on cotrimoxazole prophylaxis. Then with the children, we start them regardless of the CD4 count and regardless of the CD4 percentage. Then of course, those that are at 5 years or their CD4 percentage is greater than 25% and they're at stage 1, we can stop it. Those that are between 5 to 10 years, we can stop it based on the adult criteria, which is a CD4 count greater than 350 cells per microliter for 2 consecutive values or 2 consecutive readings. This is supposed to be values here, not weeks, values, and at least 6 months apart while they are on ART. Then we can actually stop them on the cotrimoxazole prophylaxis. So I hope this made some sense and I hope you understand. Here's a warm-up question. Cryptosporidiosis in HIV-infected patients. A, is an AIDS-defining illness if chronic? Yes, it is. B, likely to present with profuse painless diarrhea alternating with constipation. So if it had just ended at painless diarrhea, this would have been correct. C, likely to resolve spontaneously. Usually we do treat them with ART. We also treat them with some drugs to stop this. Then of course, does not improve with improved immunity. This is wrong. It does improve with improved immunity. I really hope you enjoyed this video, and indeed the last video on the treatment regimens. The next video shall look at opportunistic infections. If you did enjoy, consider subscribing. Hit the bell notification icon to be receiving notifications of such videos every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye bye.